Hello, good afternoon. My name is Kelly Rath. I'm a GYN oncologist at Ohio Health. And today we're going to talk a little bit about HPV infection, as well as the cancers, as well as other diseases associated with an HPV infection. Our objectives today are to understand HPV infection, transmission, and the burden of disease, understand related cancers and HPV diseases, as well as understand a little bit about screening and detecting both the infection as well as disease. So we'll start by talking about HPV transmission and infection. So HPV is a non-enveloped double-stranded DNA virus, and it's associated with a host of different diseases in humans. There are multiple different types of infections. Some of them are cutaneous. These are our common hand and foot warts. And then there are the mucosal types of infections, probably 40 plus. There are both high and low risk types of mucosal infections. The high risk or oncogenic subtypes of HPV are associated with cervical cancer, anogenital cancer, head and neck cancers, as well as cancer precursors, as well as low-grade cervical disease. The low risk or non-oncogenic, non-cancer forming HPV infections, 6 and 11 being most common, are associated with genital warts, laryngeal papillomatosis, as well as low-grade cervical disease. So it's important to know what type of HPV infection that we're dealing with. An HPV infection is incredibly common, with 80+% of adults or people being infected with the virus at some point in their lifetime. The majority of HPV infection is asymptomatic. It can occur with any sort of intimate sexual contact. So any mucosal to mucosal contact can spread the HPV virus. And at any time, about 1 in 4 Americans will be infected. We can routinely test for HPV infection in women. However, there's no commercially available test for men. We know that men are affected with HPV based on studies. And so when we test in studies for HPV among women with CIN, their partners have about a 60% chance of having a high-risk HPV infection and between a 9 and 30% chance of having a precancerous lesion on the penis. We also know that routine condom use is associated with increased regression of cervical dysplasia or precancerous lesions, as well as clearance of high-risk HPV infection among partners. We know that a lot of times we think about cervical cancer being the biggest problem associated with HPV infection, but cervical precancers are actually a huge problem, with about 200,000 women being impacted each year. And when we think about the cancers caused by HPV infection, we're looking about 26,000 women and 21,000 men being impacted each year. And when you look at the right side of the chart, you can see the different cancers associated, and you can see in the darker blue, the first column, the majority of these cancers are caused by either a HPV 16 or 18 infection, with the others being caused by 31, 33, 45, and then other high risks being the smaller portion. You can see among women, cervical cancer is most common, and among men, head and neck or oropharyngeal cancer is most common. This is another chart depicting the same information, showing the number of cancers per person each year among cervical, vaginal, vulvar, penile, anal, and oropharyngeal cancers, as well as the percent of those cancers that are likely to be caused by HPV infection. And so when you look at that, we're looking at almost 40,000 cancers a year that are attributable to HPV infection. And so to remember, about 90% of cervical and anal cancers, about 70% of oropharyngeal cancers, and 63% of penile cancers are linked with HPV. And so by preventing HPV, we could potentially prevent a large number of cancers. And so when we think about the ages that people are impacted by these cancers, usually these are midlife cancers in women. We can see that the majority of women that are diagnosed with cervical cancer are diagnosed with it in their late 30s or early 40s. We see that anal or oropharyngeal cancer presents later in life, and then as women age, vulvar cancer becomes almost ahead of cervical cancer as the most common HPV-related cancer. And then among men, you can see that oropharyngeal is by and large the most common cancer associated with this, and that it peaks right in the 60s. So let's talk a little bit more about cervical cancer. So cervical cancer, I think, is the cancer that most of us most commonly associate with HPV infection. We know that about 14,000 new cases are diagnosed each year with about 4,300 deaths. If you look at the chart in the bottom left of my screen, you can see that Ohio is dark blue. That means that we have one of the highest rates of cervical cancer in the country. So dark blue is not good. And so that means that we have a lot of work to do. We know that the majority of risk factors associated with cervical cancer are related to increased exposure. So multiple or high-risk partners, early onset of sexual activity, history of other sexually transmitted infections, as well as having a non-circumcised partner. We know that HPV is more likely to be persistent among non-circumcised people. We also know that immunosuppression is associated with cervical cancer because patients that are immunosuppressed are less likely to clear HPV, more likely to have persistent HPV, and then develop precancers and cancers. Non-HPV associated risk factors would be lower socioeconomic status, limiting access to healthcare as well as screening. We know that smoking increases the risk of cervical cancer, and continued research is undergoing to see, is there a genetic reason that some people are less likely to clear the HPV virus and therefore develop cervical cancer. The natural history of cervical cancer is long. Most people that are infected with an HPV infection go to the top of the slide. They have a transient infection, they clear the virus, and they don't develop any sort of HPV-related disease. Other people may have a persistent infection and over 2 to 5 years can develop low grade, go on to develop high grade disease. And usually it takes at least 9 years to develop a cancer. And so that's why this is a disease that is very amenable to screening, because there is a known precancer and a long period of development of invasive cancer. And then this is another slide I like to show just to think about what else can happen with the HPV virus. So we talked about that most people clear it. Some people develop persistent disease and develop a positive HPV test and may develop a neoplasia, a precancer, or cancer. Other patients may develop a latent controlled infection, meaning that you may have an HPV negative test and think that the virus has been cleared, but the virus may be latent and may be reactivated at another time in life. And so something that we sometimes see in the perimenopausal time. And so when we think about screening for cervical cancer, like I said, it's a cancer that takes, or precancer that takes a long time to develop, so is very amenable to screening. We use both primary HPV screening as well as co-testing. And the ASCCP is kind of our guiding body on how to screen for as well as treat precancers and cancers of the cervix, or precancers really. And in 2019, they released new guidelines. And I think one of the biggest things that they talked about was that cytology alone is no longer something that we strongly recommend for most patients, that the only time we should be using cytology alone is if we don't have access to an FDA approved HPV test. And so primary HPV screening, co-testing, or cytology alone. And when we think about screening, we want to think, what is the risk of our patients? So patients that have an average risk are patients that don't have any symptoms. So no irregular bleeding, no pain, and a normal exam. That they're immunocompetent, they don't have any immunosuppression based on diseases or medications that they're taking, and that they have a history of all normal cervical cancer screening in the past, and they have not had any excisional procedures to treat a precancer. And so we want to start at age 21 with cytology alone. And as people reach either age 25 or 30, we add in HPV co-testing, and that those patients can be tested every 5 years, either with primary HPV testing or co-testing. If HPV testing is not available, cytology, Pap tests alone could be used every 3 years. But again, HPV based testing is preferred. And when we talk about higher risk patients, those that are immunosuppressed, they do need a different screening because they are more likely to develop persistent disease as well as precancers or cancers. And so these patients would be HIV positive patients, patients who have undergone a solid organ transplant or a stem cell transplant, patients with systemic lupus, or patients that have inflammatory bowel or rheumatologic disease who are actually currently on immunosuppressive therapy. So these are the patients that are higher risk and have a little different screening. And so these patients, we want to start screening in at 21, but if they or 1 year after the onset of sexual activity. And the first screening examination includes colposcopy as well as cytology-based testing. They would continue cytology every 12 months for the first 3 years, and then moving to every 3 years. And then at co-testing, they would be on Q3-year screening. So instead of every 5-year screening, they would be on every 3-year screening. And again, in this group of patients, co-testing is also preferred after age 25. Post-hysterectomy screening. So after a woman or a person has a hysterectomy, do we need to continue screening for cervical cancer? If the cervix has been removed and the hysterectomy was not done for cervical precancer or cancer, then we don't need to continue screening for any PAP or HPV testing. If they have had a hysterectomy for one of those indications, then they may need to continue screening. If they've had a subtotal or supracervical hysterectomy, that means the cervix is still present, and cervical cancer screening should continue as they would have if the uterus had not been removed. Some patients may not be sure if the cervix has been removed or not removed, and in those patients, an examination is necessary to evaluate if the cervix is present. So when should we stop screening for cervical cancer? We used to think, age 65, we're done with cervical cancer screening, don't need to worry. And I would argue that many of these patients may still need to have screening. We know that up to 21% of patients that are diagnosed with cervical cancer are diagnosed after the age of 65. And we know that people after the age of 65 are very vibrant, have long life expectancies, and could definitely benefit from screening and early detection of this cancer. And so at age 65, if a patient has had no history of high-grade dysplasia for 25 years and has adequate screening as defined by the slide, meaning 2 consecutive negative HPV tests in 10 years, or co-testing, as well as is not having any new partners, then those patients may not need to continue cervical cancer screening. However, if you can't document adequate screening, the patient continues to have new partners, or they have a history of high-grade CIN2+, then they should continue cervical cancer screening after the age of 65 and continue on till their life expectancy, as long as their life expectancy is over 10 years. So a little bit about cervical cancer diagnosis. The majority of patients with cervical cancer are diagnosed in an early stage, and they don't have any symptoms when this is very small area of cancer. It's detected by screening with PAP and HPV testing, colposcopy, and then a biopsy after abnormal screening tests. Many times it can be difficult to diagnose some of the early cervical cancers because endocervical tumors and below the epithelium are almost impossible to visualize on exam. And so some of these patients may be the ones that we have a normal PAP, but a positive HPV indicating something higher up in the cervical canal. Additionally, if patients are symptomatic, meaning there's a mass on their cervix or a large amount of bleeding, a PAP test has up to a 50% false negative rate in those patients. And so if an abnormality is seen on exam or a patient has a lot of irregular bleeding, then colposcopy or biopsy may be very important in these patients. And when we think about prognosis, detecting the cancer early when it's stage 1 is incredibly important. And so you can see on the right side of the slide, we kind of talk about the stages of cancer. So stage 0 or carcinoma in situ, pre-cancer being 100% 5-year survival if they're treated. Stage 1 cervical cancer combined to the cervix has a pretty good survival rate, 85%, about a little almost 50% of patients are diagnosed in this stage. As we get to stage 2, stage 3, stage 4, you can see the survival rates decrease significantly. And so screening is so important to detect these cancers early, as well as HPV vaccination. Cervical cancer treatment is either surgical or chemotherapy and radiation based, depending on the size of the lesion at diagnosis. Small tumors are treated with radical hysterectomy and lymph node dissection. Patients who desire fertility and are planning future pregnancies can many times have fertility sparing surgery as long as the lesion is less than 2 centimeters. As the lesion gets larger than 4 centimeters on the cervix, these are the patients that are going to be routed towards primary chemo and radiation. And patients that have positive lymph nodes or metastatic disease may be treated with chemoradiation or metastatic disease, chemo and immunotherapy or other targeted agents. Certainly the age of immunotherapy has brought really amazing responses for some of our patients that present with late stage disease. Moving on to vulvar cancer. So vulvar cancer is less common than cervical cancer. You can see it increases as people age, about 6,000 new cases a year and 1,500 deaths a year. Risk factors are similar to cervical cancer with a history of cervical dysplasia or HPV infection, cigarette smoking. Another group of patients that get vulvar cancer is non-HPV related or lichen sclerosis. And so as people age, chronic inflammatory disease disorders of the vulva can lead to the development of a vulvar cancer not associated with HPV. Immunosuppression is also another risk factor. Like I said, the majority of these cancers are related to HPV infection, but chronic inflammation or vulvar dystrophies like lichen sclerosis also can lead to this. The majority of patients with cervical cancer have a squamous cell carcinoma, less commonly basal cell carcinoma, Bartholin's gland, sarcoma, or Paget's disease could be types of vulvar cancer. Diagnosis, most patients develop itching or burning, pain or bleeding. Delay in diagnosis of these patients is pretty common, especially as patients age. Even younger, they're hesitant to share with their physician. This area is intimate and people are a bit embarrassed sometimes. Additionally, sometimes people complain of itching and are misdiagnosed with a yeast infection. So certainly very important for these patients to have an examination. And if their primary care provider isn't somebody that's doing gynecology, referring them to see a gynecologist. An exam and a biopsy is essential. The majority of patients have local disease at diagnosis, with 59% being local, 30% being regional, meaning lymph node disease, and 6% being distant. Again, you can see stage 1 disease has a very good survival, and as the patients are diagnosed with more distant disease, the survival decreases. And so certainly important to ask patients about their vulvar health and try to catch these early. Treatment, the majority of these patients are able to be treated with surgical excision if it's local disease. Patients with lymph node disease or unresectable disease may be treated with primary chemo and radiation. And again, patients with metastatic or distant disease can be treated with chemotherapy and or immunotherapy. Vaginal cancer is the least common with only a little over 1,000 cases each year. Risk factors are similar with previous dysplasia, smoking, and immunosuppression, the majority related to HPV infection. The majority of patients are asymptomatic as the tumors are small and could be detected with PAP or HPV-based testing and those highest risk. Patients with vaginal bleeding, pain, or urinary symptoms. Diagnosis is typically based on exam and biopsy. CT scans are very difficult to diagnose a small vaginal tumor because the vagina is collapsed and a small soft tissue tumor is not able to be detected with a CT scan. Treatment is either surgical or with chemo and radiation. Anal and rectal squamous cell carcinoma, almost 10,000 new cases each year with about 1,600 deaths. HPV infection is related to more than 90% of these squamous cell, rectal, and anal cancers. Many patients present with bleeding or a rectal mass. About 20% may not have symptoms. Risk factors are men who have sex with men, a history of cervical dysplasia, vulvar dysplasia, or malignancy, a history of anal rectal condyloma. So certainly 30 to 50% risk in some of these patients versus very much lower risk. And so just kind of that same HPV infection, a history of these condyloma can increase the risk later in life of an anal cancer with persistent HPV, smoking, as well as immunosuppression. So who should we screen? So we know that HPV infection can lead to increased rates of anal dysplasia and cancer. And so risk groups that are at higher risk to consider screening are patients that have HIV, patients who have penile anal intercourse, patients who are immunosuppressed, so the transplant patients, long-term steroid use, kind of the slide that we talked about, the high-risk patients for cervical cancer are going to be the same high-risk patients for anal cancer who we should consider screening. Or people who have a history of high-grade cervical, vaginal, vulvar dysplasia. I always remind my patients that have had one of these, cervical lesions, if they have persistent HPV, we need to be thinking about anal cancer screening or history of anal warts. And so similar to cervical cancer screening, we use anal cytology with HPV-based testing, and then high resolution anoscopy, similar to colposcopy for cervical cancer. Usually colorectal surgeons are the group of people that are doing the high resolution anoscopy, or if there is a GI group that does anoscopy. And so finding a provider in your area and knowing where you can send these patients is incredibly helpful. But the majority of colorectal surgery groups are going to be doing this for their patients. And so when we think about treatment, we kind of have two places of treatment. And so patients that have a perianal skin cancer is going to be most likely treated with a wide excision. So a small 2-centimeter lesion that's not invading into the anal canal, not involving the sphincter, can be treated with excision. Those patients that have a true anal canal cancer, or rectal cancer, are typically treated with primary chemo and radiation. And again, you can see the survival for small tumors that are not lymph node positive is good. As the tumors become larger, more locally invasive, or lymph nodes are positive, the survival decreases. Head and neck cancer. So HPV-related head and neck cancer is the most common HPV-related cancer in men. The chart on the right side of the slide shows oropharyngeal cancer in women. At the bottom, it's very low. It has been stable. When we look at cervical cancer, we see that it is decreasing. However, when we look at head and neck cancer, we see that it is increasing. And these head and neck cancers are those that are kind of at the base of the tongue and the tonsils. And there's no effective screening tool for head and neck cancer at this time. And we'll talk a little bit more of that in the coming slides. When we think about the incidence, we have about 20,000 new cases each year. Risk factors are going to be similar with HPV infection, smoking, and immunosuppression. The majority of patients were going to present with a neck mass, less likely to have trouble or painful swallowing symptoms. Many times these patients are diagnosed by their dentist when they're kind of feeling back or they notice a mass on the neck. The diagnosis is by examination, direct laryngoscopy, and then biopsy or a fine needle aspiration of the neck mass. The majority of these patients are treated with radiation and chemotherapy. We know that there are some knowns about the natural history of head and neck cancer, and there are some unknowns about the natural history of head and neck cancer. We know that there is an exposure to HPV, a risk factor being oral sex. We know that there is oral HPV infection, men or current smokers. We know that most people will clear this infection. We know that persistent HPV infection develops over years. Patients who are older, male sex, smoking, and immunosuppression may increase this persistence. We haven't detected a known precursor lesion. And we know that over decades, but we don't know what the progression risk truly is to oropharyngeal cancer. We've detected systemic antibodies on testing, as well as we've been able to detect oral HPV DNA. But again, screening is limited by lack of a known precursor and this inability to detect an early malignancy, and there aren't any mitigation strategies. And so lots of people are working on this. We kind of have a natural history, but there are still some questions. When we think about treatment, small tumors could be treated with surgical excision and negative margins. Some patients may need radiation, and locally advanced disease. Again, the kind of key for most of these is surgical excision if it's small, and a combination of chemo and radiation if it's large, with metastatic disease being treated by chemotherapy plus or minus immunotherapy. So a final reminder, HPV is linked with 91% of cervical and anal cancers, 70% of head and neck cancers, and 60% of penile cancers. And so that is what we have today about HPV-related cancers, disease, and infection. Thanks.